Well, good morning. Our lecture today is Articulators, Transfer Record, and Study Cast. Well, new technologies are transforming clinical practice from clinical data capture and analysis to a virtual clinical environment for case planning. The progression of computer-aided design and computer-aided manufacture CAD/CAM is creating the plasterless laboratory. Well, in spite of the advancement, the articulator will remain a relevant component of restorative dentistry. In traditional contexts, casts of patient dental arches are placed on articulator to assess the dental occlusion and to allow construction of dental prostheses and indirect restoration. Well, actually, in spite of all the advancement, still we need the traditional articulators, especially in developing countries and the Middle East. We need traditional articulators in order to make your dental prostheses, whether it is a removable or fixed, and even a dental implant. Well, there are many designs of articulator, and each to a greater or lesser extent reproduces the relationship of the patient maxilla to a mandible, at least as a static relationship. Well, simply an articulator is a mechanical instrument that represents the TMJ and jaws to which maxillary and mandibular cast may be attached to simulate some or all mandibular movement. I say to simulate because whatever advancement in the articulator's manufacturing, still we cannot capture or cannot duplicate all mandibular movement because we are dealing with a human being, soft tissue and muscles, and articulator is actually made of metal, so you could not duplicate. It's rather to say to simulate some or all mandibular movement. Well, there are many classifications of articulators, but I pick up to you this classification, which says that the articulators could be classified into the non-adjustable articulator, the semi-adjustable articulator, and fully adjustable articulator. Well, the non-adjustable one could be a hinge and a mean value, and the semi-adjustable could be the arcon and the non-arcon, and the fully adjustable could be with one with a pantographic tracing and the other one with the stereographic, and we are going to explain each classification later on in this lecture. Well, another classification according to a glossary of prosthodontic terms in 2017, it classify articulator into class 1, 2, and 3, and 4. So class 1, it will be a simple holding instrument capable of accepting a single static registration. Vertical motion is possible. Really, it is a simple one. You can only open and close the members of the articulators, so it's acceptable only in a vertical movement, not in eccentric movement. This is the class 1 articulators. Well, the class 2 articulators, or could be the mean value articulators, it is an instrument that permits horizontal as well as vertical motion, but does not orient the motion to the TMJ. This is like a mean value. You could accept vertical and horizontal, the centric relation, but will not accept a facebow transfer. Okay. Well, the class 3 articulators or the semi-adjustable articulators, it is more advanced than the class 1 and 2. It is an instrument that simulates condylar pathway by using averages or mechanical equivalent for all or part of the motion. These instruments allow for orientation of the cast relative to the joint and may be arcon or non-arcon instrument. Well, I'm going to explain what's mean by arcon and non-arcon instrument later on. And the last classification will be the glass 4 articulator. It is a complicated one. It accepts 3D dynamic restoration. That's mean in horizontal, frontal, and sagittal. These instruments allow for orientation of the cast to the TMJ and simulation of mandibular movement. Actually, we need a kinematic type of facebow and a pantograph in order to program these articulators. Well, there are many designs of articulators, but in general, there are 4 different types: the simple hinge articulator, the average value or the plain line articulator, semi-adjustable, and fully adjustable. Well, as you can see, this is a simple hinge articulators to provide a single hinge movement without lateral movement. Well, the main drawback of this instrument is the distance of the maxillary arch to the intercondylar axis is much less than in the patient, and therefore intercuspal position recording are an approximation, and they have a limited application. As you can see, the disadvantage of a simple articulators, as you can see, the arc of closure in A, which is the semi-adjustable articulator, is much resemble the one on the human being, but the arc of closure and in B, the arc of closure is very close to the intercondylar axis. This might cause a premature contact at the try-in. So therefore, if you want to make a fixed prosthesis, at least you have to use a semi-adjustable articulator, so to minimize the interferences at the premolars area, because the arc of closure is much closer to the intercondylar axis in the simple one, but it is close to the human being in semi-adjustable articulators. So it is an advantageous to use a semi-adjustable on the arcon one to have good centric occlusion rather than premature contact. Well, this is the mean value articulators, or they call the average value articulator. Their condylar angle is fixed at 30° and some says at 33°. There is no provision for adjustment for condylar side shift, but they may have an adjustable incisal guidance. Well, the side shift or the lateral movement, it's fixed according to studies. It says that the average is 30 or 33. Well, it is made according to the theory of Banwell, so it is, I call it the Banwell triangle, as you can see in the right slide, which is say that the distance between each condyles could be 4 inches or 10 centimeters, and the distance from each condyles to the lower central incisor, it is also a 4 inch. So he made a mean value articulator according to these principles. Well, the passable movement of mean value articulator or fixed condylar path articulator is opening and closing. Protrusive movement at a fixed condylar path angle, as I said. And the passable record required for such an instrument is vertical dimension of occlusion, centric relation, facebow transfer record. Not all design. In some design of this articulator, the upper cast could be mounted by a facebow transfer, but mostly it could not accept a facebow record. So when articulator does not accept facebow record, the mounting is made according to the Banwell triangle, which I explained previously. Well, semi-adjustable articulators or the glass 3 articulator. Actually, they accept facebow transfer and allow adjustment of intercondylar inclination and side shift or lateral movement, and in some design for Bennett movement or immediate side shift. Well, the intercondylar width is usually fixed at 110 millimeters, but some articulator allow different intercondylar width setting. Well, as I said, these are the most widely used in dental practice. It accepts vertical, horizontal, centric, and eccentric movement, and also a facebow transfer is allowed on this instrument. These articulator may be either argon or non-argon in the design, and what's meant by an argon is it's the acronym for articulator condyle, يعني, which I mean the argon, it means articulated condyle, okay? And the non-argon, this is the opposite of the human being. I'm going to explain. So, as you can see in this picture, this is an example of argon semi-adjustable articulator, which I mean the articulated condyle. In the argon articulator, the condyle, it's like human, it's fixed on the lower members, but the condyle pathway is in the upper member like a human being. So therefore, they call it the argon articulator, like the whip mix and the Hano articulator, as you can see on these pictures. And these are the non-argon articulator, which is the opposite of the human being, which I mean that the condyle is in the upper, as you can see, this is the condyle ball in the upper member, and the condyle path is in the lower member. So they call it the non-adjustable, the semi-adjustable, the non-argon semi-adjustable articulators. As you can see, this is the condylar ball attached to the upper member, and the condyle path is in the lower member. It's the opposite of a human being. Just I'm going to show you the difference. The upper is the non-argon, and the lower is the argon, which means the condylar ball is in the lower and the path is in the upper. Well, this picture shows the differences between the argon semi-adjustable articulator and the non-argon semi-adjustable articulator. The picture on the left, this is the argon articulator, in which the condyle head is attached to the lower member and the condyle pathway to the upper. And the one on the right side, this is the non-argon semi-adjustable articulator, in which the condylar ball attached to the upper member and the condylar path to the lower member. Well, the main difference between the argon articulator and the non-argon articulator, as you can see in this figure. Well, in figure A, you know that the angles, as you can see, the angle that's formed between the occlusal plane and the condylar inclination is fixed. In argon articulator, when the patient open and close his jaws, the angle is fixed between the condylar inclination and the occlusal plane, while in the non-argon articulators, the angle is a little bit different when the patient, as you can see, this is the angle when the patient closes. When they open, there's a little bit difference between these angles during opening and closure. What this might cause when you're programming the condylar inclination by using a protrusive record, it may cause some errors in the non-argon types, but with more approximation for a human being in the argon articulator. So therefore, when you try to do a full mouth rehabilitation or a bridge with long span, it's advisable to use the argon articulators to minimize the error in programming the articulators and minimize the error in occlusion. Well, the fully adjustable articulators, you will not use it, but for your knowledge, it is a complicated instrument, and it has complicated design, and the transfer of record from the patient are believed to allow closer reproduction of condylar movement. Well, as I said, these articulators are designed to simulate or duplicate the TMJ joint features by a series of condylar adjustment, and also allow curved condylar translation path. The condylar setting may be determined by pantographic tracing and stereographic record. Well, this is used only for those interested in research methodology and gnathology, and those who for full mouth rehabilitation, and those with good knowledge to how to use this instrument and how to transfer this record from the patient to the instrument, because any error in any step, it will complicate the whole procedure. Well, these are examples of a fully adjustable articulator as the dinner. They call it the dinner. You know that it is setting intercondylar distance. It could be simulate that of the patient, and also you can transfer the Bennett movement, the immediate side shift of the patient, and the condylar inclination. It could be programs according to a pantographic tracing. As I said, it's a complicated procedure and need enough knowledge from the. As I said, for programming these fully adjustable articulators, you need what's called a pantograph, which is simply consists of two facebow, one fixed to the maxilla while the other is to the mandible, and these it will transfer the mandibular movement in a three-plane, horizontal, sagittal, and frontal. As you can see, these are the movement of the condyle and the movement of the mandible in the anterior region. And this is a pantographic tracing, complicated. It has a stylus in the upper and a graphic paper in the lower, and you must give good instruction to the patient how to move the mandible, and you can guide the mandible to the retruded position and to the eccentric position, and by doing so, the stylus will trace the mandibular movement on these graphic papers. This is simply what you will get after doing the pantograph tracing. It will trace the mandible. As you can see, the double is the working and the non-working, and for protrusion near the condylar side, and in the anterior region you have two stylus. It will trace the mandible into protrusion, retruded, working, and the non-working side. Well, in a stage of using complicating instrument, there is the digital pantographic recording. It will trace the mandible computerized on the screen. This is just for your knowledge. But however, the accuracy has been always questions, and no control studies have verified the accuracy. However, it would be assumed that repeated use by experienced clinician would inevitably provide greater accuracy. As I said, it is a very complicated instrument, and any error in any step will complicate the whole procedures. For knowledge, I'm going to explain what's meant by a stereographic tracing. It means that, as I said, is the one who's interested in occlusion And in full mouth rehabilitation, you could use a stereograph rather than using a pantograph for programming for the fully adjustable articulators. Well, the stereograph consists of two clutches. The upper one has a central bearing device, and the lower you could put four silicone putties, and you insert these clutches inside the patient mouth, and the patient should be educated, and you start to do maneuvering of the mandible to the centric protrusion and to the right and to the left. And by doing so, the tracer, as you can see in this diagram, it will trace the mandibular movement into the protrusion and to the working and to the non-working, the lateral movement. Okay, as I say, this is a complicating procedure and take experience from the patient. This is the stereographic tracing, putty and stylus. Okay, the stereographic tracing is transferred from the patient mouth to the articulators, and if you want to be more accurate, they use what's called the custom molded condylar inclination. It's also by using a putty, and you start to move the mandible to the right and to the left and to the centric, and you will get what is called a custom made condylar inclination. And here is using a Bolly gauge to measure the Bennett shift. As I say, this is just for your knowledge to understand what's meant by stereographic tracing and a mold for the silicon, made of silicon, a custom made condylar inclination made from silicon putty. Well, I am going to jump into another object. This is the facebow. Well, simply a facebow, it is an instrument that records the relationship of the maxilla to the hinge axis of the mandible. It allows the maxillary cast to be placed in an equivalent relationship on the articulator. As you can see in this figure, transfer the relation of the maxilla to the hinge axis of the mandible, and then the same relation will be transferred to the articulators. Well, the main advantage of facebow is to record the orientation of the maxilla to the terminal hinge axis, as well as to provide the same relative opening axis on the articulator as the mandible has to the TMJ. As you can see in the right figure, what's meant by a hinge axis, it is a hypothetical line through the two mandible condyles around which the mandible might rotate. As you can see here, this is the mandible, and this is the terminal hinge axis, and the mandible may rotate through it. Well, to identify the hinge axis, it is necessary to use a hinge axis locator and hinge axis facebow. More commonly, the average value, or they call it the arbitrary facebow, are acceptable and adequate. But for more accurate and for more precise hinge axis location, you can use what is called a kinematic type of facebow. But mostly, in fixed and removable, we are using arbitrary axis facebow. It uses an arbitrary hinge axis location that is located at a point 12 or 13 millimeters along a line drawn from the upper aspect of the superior border of the tragus of the ear to the outer canthus of the eye. Well, this is different type of facebow. The one on the left, this is an arbitrary facebow, an ear facebow, and this is a Hano facebow. It will locate the hinge at approximation about 12 to 13 millimeter in front of the tragus of the ear, and these are on the right side. These are the auricular facebow, and this is the hano using in front of the tragus of the ear. As you can see in the lower left side, this picture using an arbitrary facebow, and this is the condylar rod attached to the skin in front of the tragus of the ear, 13 millimeters. And this is the complicated, this is the one on the right side of the screen. These two figures are the kinematic facebow. It is attached to the lower, and it is not used in a dentulous patient. Mostly on dentulous patient, it has a clutches attached to the lower, and the true hinge axis location is by just ask the patient to open and close the mandible till the stylus rotate in a state of translation to locate the true hinge axis of the mandible. This is just for your knowledge. Well, as I said, true hinge axis location by using the kinematic facebow, really it is difficult to determine, especially in a dentulous patient, and requires special armamentarium, and it's mostly used in dentulous patients, those with full mouth rehabilitation. But the most popular one is the lower one in the screen. It's called the arbitrary hinge axis facebow. It is an estimated location using any of the current technique. It will place the position with an accuracy within plus minus 6 millimeters of the true hinge axis. Well, the earbow usually use the external auditory meatus as a reference point as the arbitrary hinge axis location. Anyway, when you are using an arbitrary hinge axis for determination of the relation of the maxillary to the true hinge axis, you have to determine 3 points, 2 on the posteriors and 1 on the anterior. The 2 posterior points will be in the front of the tragus of the ear or the external auditory meatus, and the anterior point mostly will be the infraorbital or the nasion. Well, this picture shows you how to record the relation of the maxillary to the hinge axis of the mandible. As you can see on the right side, they use an arbitrary ear facebow. The 2 reference points on the posterior will be the auricular, the external acoustic meatus, and the anterior reference point will be a point about 40 millimeters above the lateral incisors. And in some arbitrary facebow, they use the nasion as the 3rd point or the infraorbital foramen as the 3rd reference point. Well, the picture on the left side shows you how to point the 3rd reference point in the anterior part of the face, which is approximately located about 40 millimeters above the lateral incisors. As I said, this is the transfer record from by using a facebow from the patient mouth to the articulators. As I said, it could be used for both dentulous and anisculous patient. Well, this is a semi-adjustable articulator with arbitrary facebow transfers, and you can see the relation it transfers accurately to the condyle from the patient mouth to the articulators. Well, we jump to other subject. Is the study cast. Well, the study cast should be obtained from accurate impression that record the complete dental arch and ridge and fossa area to allow reproduction of all tissue contour. Well, alginate impression are good, but if you want to be more precise, you can use silicone impression material, which is more accurate dimensional stable and produce superior surface details. Well, the main advantage of articulated casts is it will enable you to have a good analysis of the occlusal plane, the occlusion, and the diagnostic procedure can be performed for a better diagnosis and treatment plan. Also, to allow you to do tooth preparation can be rehearsed on the cast, and diagnostic waxing procedure allow evaluation of the eventual outcome of the proposed treatment, also used for occlusal analysis. Well, simply if you want to do a good alternate impression, after starting mixing the proper amount of Alginate precision material according to manufacturer instruction, you can use your index fingers to put a small amount on the occlusal surfaces of the teeth before loading the main bulk of the impression material inside the patient mouth. And you can see in figure D, this is a nice captured impression for the dental arch without error. This figures show you a cast with good surface details on the lower stone, but it has not good details on the upper. You can see nodules of stone. This will complicate the occlusal analysis of the patient. This is a nicely mounted on the right side, a nicely mounted upper and lower diagnostic cast on a semi-adjustable articulators. Well, to have a proper occlusal analysis, which is done on the diagnostic cast, you have to transfer record from the patient mouth to the articulators. Well, the first record is the retruded contact position, the RCP or the Centric Relation Record. This is an important record. It is used to articulate cast for diagnosis and treatment planning. The CR, the centric record, is recorded with the teeth slightly apart in order to avoid any deflection by tooth contact. This is very important. If you want to transfer the centric record by using an interocclusal wax, the patient should not penetrate the wax. The teeth should be slightly apart. As you can see, how to transfer record from the patient mouth to the articulators, you can use a wax which is slightly adapted on the cast, and then these wax are transferred from after you guide the patient to close into centric relation, as I said, with the teeth slightly apart without any perforation, and then you transfer record, as you can see in these figures, from the patient mouth to the articulators, and then do mounting. Also, if you want to have a more accurate registration of interocclusal record, you can use a wax relined by zinc oxide eugenol. It is a more stable record than using a wax only. These figures show you the differences when you have an interocclusal record with perforation and without perforation. As you can see in the upper slide, if you the wax is not perforated, but in the lower figures, if you take the centric relation record and the patient is tightly closed into centric relation, you may perforate the wax, as you can see in the lower slide, and the condyle will be displaced posteriorly and downward. So at the trial, as you can see on the right figure, it will be good on the articulators, but when you check your trial waxing or trial bridge of the patient mouth, on the lower left side there will be slight opening anteriorly, because the mandible, the head of the condyle, will return back into its correct position, which might cause error occlusion. So you should never perforate the wax when you take an interocclusal. Well, how to verify your centric record or retruded contact position on the diagnostic cast on the diagnostic cast on the articulator. As you can see on this figure, he used a Keir indicator wax that should be inserted inside the patient mouth and ask the patient to close into the retruded contact position. And after that, as you can see in the figure B, the wax is returned back on the articulators, and the shadow of area of first contact will be shown through these green wax, and you should point these shadows by using a marker like a pencil. As you can see in the lower figure C, the first area of contact is here, and the first molar on the right side, and the third molar on the left side. This is the first area of contact, and after you want to verify that your record is correct, you just put an articulating paper with different color of the pencil marker, and you close your articulator, and you see that there's coincidence of the contacts between the one you record and the one from the patient mouth. That means that your record is correct. Or if it is incorrect, it means that there is another tooth in contact rather than the first molar and third molars. Okay. Well, if you face difficulty in recording the centric jaw relation, you can use what is called an anterior programming device. It consists of a small piece of doff of acrylic, and you can ask the patient to close so gently without contact at least 1 millimeters of space in the posterior segment. You guide the mandible to close into this programming device, and then you remove this programming device, and you just do proper trimming of this device, and you return it back to the patient mouth. And if the patient repeat correctly to close into centric jaw relation, just go ahead. You can put, as you can see on the left figure, you just insert a silicone registration material and ask the patient to close. As you can see, this is the registration material of centric jaw relation. Or instead of using a silicone, you can use zinc oxide using oil and a gauze and guide the patient to close into centric relation. Well, the lateral and protrusive record, it could be transferred by using waxes or intercrucial record from the patient mouth, or it could be transferred by using a complicated, as I say, the graphic tracing or pantographic tracing. Well, if you wish to record the protrusive and the eccentric records, as you can see on the upper figures, A, you insert 3 layers of wax and protrude the mandible till edge to edge. This is for protrusive record. And D and E, this is for the lateral record. You guide, also use a 3 layer of wax, and you guide the mandible till you have canine edge to edge position, and this record to be transferred to the articulator in order to program the semi-adjustable articulators. Well, the dynamic record could be in a single plane, as in horizontal, or pantographic tracing in 3 planes, or stereographic recording, or what is called wireless motion sensors, using sensors on the patient's skins, and by Bluetooth it is connected to the computers. Okay. The data are transferred via Bluetooth connection to our computers. Need a good knowledge on how to use these sensors. Well, and briefly, how to select a proper articulator. As I said, for simple hinge articulator, these are of limited value in dentistry, but will allow you a preliminary evaluation of static tooth arrangement on steady cast, and also aid in discussion of the cases in front of your patient. The average value articulator or the mean value or the fixed condylar path articulators. These articulators produce an approximation of condylar movement and may be used for construction of a simple indirect restoration and may be used for partial and complete denture construction. Well, the semi-adjustable articulator are the most popular one for restorative and prosthodontic purposes, articulating the cast using the RCP centric record allow an examination of retruded contact position features, and also you could examine the RCP to ICP, which means the difference between centric relation and centric occlusion. Well, the decision whether to use an argon or non-argon semi-adjustable articulator is largely a matter of operator preference. However, arcon articulator reproduce the anatomical relationship of the patient maxilla and mandible to the intercondylar axis. As I said previously, it is more accurate than the non-arcon one. The fully adjustable articulators have the potential to provide the most accurate replication of the jaw relation, but however they are complicated instruments and are technique sensitive, and the complex condylar adjustment for individual patients require pantographic tracing. Well, their indication, the fully adjustable articulator has been principally for extensive fixed prosthodontics and restorative dentistry, with the assumption that all aspects of fixed prosthodontics laboratory work can be completed on such articulators. Well, and the least fully adjustable articulator are seldom used in clinical practice because semi-adjustable articulators with a clinical verification adjustment where indicated has become the acceptable approach and the most popular one. Well, recently there is the virtual articulators. So recent software development include virtual articulators, virtual casts usually derived from an optical scan, can be positioned within the framework of the virtual articulators, and several of these have some degree of adjustability of condylar control. Well, in spite of these advancements, there's as I say, there is some limitation of these virtual articulator as they are cost effective and it require digital scanners, digital sensors, and a good knowledge of the software and the knowledge about the CAD-CAM technology. And thank you.